Section 3. Variant classifications are tiered to reflect certainty. 3.1. Germline variant classification tiers. Variant classification has traditionally been treated as art of medicine rather than science, which is why it has gone largely unregulated in the United States. Art of medicine falls under clinician licensure rather than Clinical Laboratory Improvement Amendments, CLIA, or College of American Pathologists, CAP, accreditation. To assist in the art of medicine, in 2000, the American College of Medical Genetics and Genomics, ACMG, published an original set of variant classification standards for monogenic disorder germline variants, which was followed by a 2007 revision. While the general concepts of these standards were adopted by many laboratories, the implementation details and classification terminology, which had not been provided, varied greatly across laboratories. In 2013, a work group consisting of members of the ACMG, CAP, and the Association for Molecular Pathology, AMP, organized to develop standard terminology for germline variant classifications and to make evidence requirements and classification algorithms more stringent. The result was a 5-tier classification system. These classifications could be calculated using an additive algorithm from specified evidence categories labeled standalone, very strong, strong, moderate, or supporting. The 2015 guidelines were titled Standards and Guidelines for the Interpretation of Sequence Variants, a joint consensus recommendation of the American College of Medical Genetics and Genomics and the Association for Molecular Pathology. The 5 tiers of germline variant classification were pathogenic, likely pathogenic, benign, likely benign, and variant of uncertain significance, VUS, or V of US. The guidelines recommended that variants be reported with respect to the relevant genetic disorder and inheritance pattern. It was also stressed that professional judgment should be used when implementing and adapting the guidelines. A survey of the germline clinical genetics community, as described in the 2015 guidelines, determined that a 90% certainty was sufficient to describe a variant as either likely pathogenic or likely benign. Reference was also made to the International Agency for Research on Cancer's recommendation that a 95% level of certainty be applied to variants classified as pathogenic. However, sufficiently large orthogonally validated truth sets are not publicly available to actually quantify laboratory certainty of variant classifications. Therefore, the certainty concept remains aspirationally qualitative. In most clinical scenarios, both the pathogenic and likely pathogenic variant classifications are considered positive results that may alter care, with appropriate consideration to inheritance patterns. The benign, likely benign, and VUS classifications are generally considered results that do not change care. Certain clinical scenarios may warrant the treatment of a VUS as a candidate positive finding when other diagnostic opportunities have been exhausted, such as in the pediatric setting for patients in rapid decline. Copy number variants, i.e., large deletions and gains, such as insertions, duplication, and triplications at the exon and gene size scale, have long been detected by technologies other than sequencing technologies. However, NGS has advanced to being able to detect some of these types of larger variants. Until 2019, copy number variants had their own classification categories. However, in the 2020 publication, Technical Standards for the Interpretation and Reporting of Constitutional Copy Number Variants, a joint consensus recommendation of the American College of Medical Genetics and Genomics and the Clinical Genome Resource, ClinGen, the classification system was uncoupled from individual patients and aligned to the 5-tier classification system, matching the 2015 ACMG AMP sequence variant classification guidelines. Section 3.2. Somatic variant classification tiers. Somatic variants in cancer, also known as acquired variants, may be used for diagnosis, for prognosis, and/or to guide therapy selection. Detected variants in these tests are frequently reported along with variant allele frequencies measured within each unique patient sample to estimate the probability of variants being germline and to evaluate tumor clonal diversity. Sometimes normal patient matched tissue is also used as a comparison, with the aim to distinguish somatic variants from germline variants. However, what is considered normal tissue is not straightforward, and different laboratories may approach this challenge differently, yielding different results, while some laboratories opt to use computational methods instead. The first somatic variant classification guidelines were published in 2017 and remain current, though an update effort began organizing in 2020. The 2017 standards have not been broadly adopted by laboratories, though the general concepts are found in almost all somatic testing laboratories. Already established laboratories with optimized protocols have been less likely to adopt the guidelines. The 2017 Somatic Classification Guidelines, titled Standards and Guidelines for the Interpretation and Reporting of Sequence Variants in Cancer, a joint consensus recommendation of the Association for Molecular Pathology, American Society of Clinical Oncology, and the College of American Pathologists, recommends a 4-tier system with the following evidence requirements, as summarized in Figure 2 of those guidelines. Tier 1, variants of strong clinical significance, includes Level A evidence, FDA-approved therapies, and are included in professional guidelines. Level B evidence is well-powered studies with consensus from experts in the field. Tier 2 are variants of potential clinical significance and include Level C evidence, FDA-approved therapies for different tumor types of investigational therapies, and multiple small published studies with some consensus, and Level D evidence, preclinical trials or a few case reports without consensus. Tier 3, or variants of unknown clinical significance, these are not observed at a significant allele frequency in the general or specific subpopulation databases, or pan-cancer or tumor-specific variant databases, and no convincing published evidence of cancer association. Tier 4 are benign or likely benign variants, which are observed at significant allele frequency in the general or specific subpopulation databases, and there are no existing published evidence of cancer association. The same 4-tier system was used in the 2019 guidelines, titled Technical Laboratory Standards for Interpretation and Reporting of Acquired Copy Number Abnormalities and Copy-Neutral Loss of Heterozygosity in Neoplastic Disorders, a joint consensus recommendation from the American College of Medical Genetics and Genomics and the Cancer Genomics Consortium. Clinicians feel most confident in disclosing both Tier 1 and Tier 2 results to patients to inform patient care.